All right, welcome. If you're gearing up for step 2 or step 3, you know that some topics are just classic traps. And today, we are going to break down two of the biggest ones, rhinitis and glucocorticoids. So don't think of this as a lecture. This is your high-yield strategy guide to see those traps coming a mile away and just absolutely nail these questions.
Okay, so here's our game plan. First, we're going to look at the 4 different phases of rhinitis and how to tell them apart. Then, we'll dive right into that classic rebound congestion trap. From there, we'll get into the big differences between systemic and local steroids. After that, we'll put it all to the test with some board-style questions, and we'll wrap things up with a super quick, rapid-fire review. All right, first up, the 4 phases of rhinitis. Now, I know it sounds pretty simple, right? But believe me, the exam loves to get tricky with the subtle differences. And if you get the diagnosis wrong, you're going to get the management wrong. So let's make sure we have this down cold. Okay, let's zoom in on the 2 most common chronic types, because the test wants you to mix these up. But here's the super simple way to think about it. Ask yourself, does the question mention sneezing, itching, a seasonal pattern? If the answer is yes, boom, your brain should immediately go to IgE-mediated allergic rhinitis. If those things are missing, and it's more about this year-round stuffiness that gets triggered by, cold air or strong smells, you're looking at non-allergic rhinitis. That right there is your first critical decision point. And here is another absolute classic board question setup. It all comes down to one little physical exam finding. What does the nasal mucosa look like? This is a huge clue. For allergic rhinitis, you're going to see pale, swollen, kind of boggy tissue. Think chronic inflammation. But for infectious rhinitis, the common cold, that mucosa is going to be erythematous. It's red, it's angry, it's screaming acute viral infection. One look tells you the whole story. All right, let's move on to a management trap that the exam writers just love. Seriously. It's called rebound congestion, and it's a pitfall that comes directly from a very common treatment people use. You've got to know the name for this, rhinitis medicamentosa. The vignette is practically going to spell it out for you. It'll be a patient who started using a nasal spray like oxymetazoline, felt amazing for a couple of days, but now, maybe a week later, they are more stuffed up than they've ever been. The key, the absolute giveaway, is the duration of use. Anything more than 3 days is the classic trigger for this whole rebound mess.
So, when that question inevitably asks for the next best step, this is the 3-step plan you need burned into your memory. Number 1, and there's no negotiating this, they have to stop using the decongestant spray immediately. Number 2, you start them on intranasal steroids to calm all that inflammation down. And number 3, you can use saline irrigation to help with the symptoms. You've got to lock that pathway in.
Now, let's pivot a bit and talk about the treatment itself, glucocorticoids. These are incredibly powerful drugs, but the exam is absolutely going to test you on the huge difference in side effects depending on how they're given. It's the definition of a double-edged sword. So whenever you see a patient on long-term oral prednisone in a question, a giant list of systemic side effects should just explode in your mind. We're talking about everything from the classic Cushingoid appearance and high blood sugar to osteoporosis and, of course, adrenal suppression. These are widespread, high-yield problems. But now, look at the contrast with localized steroids. The side effects are pretty much just stuck to where you apply the drug. For an inhaled steroid, the big one is oral thrush. For an intranasal spray, it's maybe some nosebleeds. And for a topical cream, you get skin thinning. The systemic absorption is tiny, which makes them way, way safer for long-term use. This difference is everything on management questions. And here is a safety point you just cannot afford to miss. Not for the exam and not in real life. If a patient has been on systemic steroids for more than 3 weeks, their own adrenal glands have basically gone on vacation. If you stop the steroids suddenly, you can throw them into a life-threatening adrenal crisis. You have to taper them. Okay, theory is one thing, but let's actually apply this stuff to some classic exam vignettes. This is exactly how you're going to see these ideas pop up, and this is how you can break them down and get to the right answer, fast. All right, let's break this one down. The second you read oxymetazoline for 10 days, alarm bells should be screaming in your head, rhinitis medicamentosa. Now, check out the distractor they threw in, erythematous nasal mucosa. They want you to see that red color and think infection. Don't take the bait. That 10-day history of the spray is the key piece of information, and it trumps everything else.
And there it is. The answer is a direct application of that management plan we just talked about. You're not treating an infection, you're treating the rebound. So you stop the decongestant and you start the intranasal steroid. This is a pattern you have to recognize instantly on test day.
So this next one is a direct test of that super important safety point. You see long-term prednisone, 6 months is a classic giveaway, and then they abruptly stop. The moment you see that combination, you should already be looking for signs of adrenal collapse. And what do you know? There they are. Fatigue, nausea, and the really big one, hypotension.
This is exactly that life-threatening condition we warned about. The diagnosis is adrenal crisis from secondary adrenal insufficiency. And the immediate next step isn't just one thing, it's aggressive resuscitation. We need to give IV hydrocortisone and IV fluids to replace what their body just can't make on its own anymore.
Okay, final scenario here. We're shifting gears to a localized side effect. We've got a patient with asthma. She's on an inhaled corticosteroid, fluticasone, and she has these classic white plaques in her mouth. This is a total textbook presentation. So the question is, what are you going to do about it?
So the diagnosis is obviously oral candidiasis, or thrush. But, and this is key, the next best step on the exam is often a two-part answer. You have to treat the infection that's there right now, usually with something like oral nystatin. But you also have to give that crucial piece of preventative advice. Always, always rinse your mouth out with water after using your inhaler. The exam expects you to know both parts.
Okay, let's pull all of this together now. We're going to boil everything we've just talked about down into a final rapid review format that you can just pull up in your mind when you're sitting there on exam day.
Think of this table as your mental cheat sheet. Allergic? Think EG, pale mucosa, itching. Non-allergic? No itching, just those vasomotor triggers. Infectious? That's your common cold with red mucosa. And medicamentosa? That's the rebound from overusing decongestants. Knowing these key features is how you'll tell them apart when you're under pressure.
And for glucocorticoids, these are the absolute must-knows. Systemic steroids for more than 3 weeks, you taper. Inhaled steroids, you rinse your mouth. Topical steroids, they can cause skin atrophy. And don't forget, ophthalmic steroids can lead to cataracts and glaucoma. These are the highest of the high-yield associations.
So there you have it. You know the patterns now. You've seen the traps laid out. The next time a question mentions long-term oxymetazoline or a patient who suddenly stopped their prednisone, you're not just going to see a question anymore. You're going to see the answer. So the only question left is, are you ready to spot them?